Hello everyone, this is Dr. Sally Temraz. I will be giving you the second part of the hemostasis lecture that deals actually with platelets, as the first part that deals with coagulation pathways will be given by Dr. Hazem Asi. So again, the platelet disorders lecture is part of the hemostasis lecture that I will be dealing with in this presentation. So what are platelets? So platelets are formed in the red bone marrow by fragmentation of megakaryocytes. So the mother of the platelets is the megakaryocytes. And what are the megakaryocytes? The megakaryocytes are cells that are 10 to 15 times larger than typical red blood cells. They measure approximately 50 to 100 microns in diameter. During its maturation, the megakaryocyte grows in size and replicates. So during its maturation, the megakaryocyte, as you can see here, grows in size and replicates its DNA in a process called endomitosis. So as a result, the nucleus of the megakaryocyte, as you can see here, becomes very large and lobulated, which under the light microscope gives the false impression that there are several nuclei. Okay, so this is one single nucleus that gives the false impression that there are several nuclei. This is the structure of the megakaryocyte under the microscope that you can see. Now this is the ultrastructure of platelets. So like any other cell, the platelets has a plasma membrane. It has certain inclusion bodies, the electron-dense granules, and the specific alpha granules. And it is very important for us to know what are these granules, as these granules are very important for the process of hemostasis and in particular for the function of the platelets, because without these granules, the platelet cannot perform its function. And I will discuss this in detail in later slides. So the platelet peripheral zone contains the glycocalyx and the plasma membrane. So the plasma membrane and the open canalicular system are very important as they contain the platelet phospholipid, which is also very important for the process of hemostasis, which I'm going to show you in my coming slides. The platelet also has a mitochondria like any other cell, dense tubular system, glycogen, and others. So the most important thing from this slide is to know the electron-dense granules that are very, very important and specific to the function of the platelets. So the electron-dense granules are the ADP, the calcium, and the serotonin. The alpha granules include the fibrinogen, factor V, von Willebrand factor, fibronectin, beta-thrombomodulin, thrombospondin, and so on. So these again are very important for the function of the platelets that I will be discussing shortly. Now, how are platelets distributed in our body? So under normal conditions, the majority of platelets are circulating in the blood, and only about 1/3 of the platelets will be present in the spleen. However, in pathological conditions, what we call splenomegaly, whereby the spleen is enlarged, the majority of platelets will be pooled in the spleen. So around 60 to 90% of platelets will be stuck in the spleen, and the remainder, 10 to 40%, will be circulating in peripheral blood. This is a very important slide that summarizes the process of hemostasis all over our body, including the coagulation factors, the platelet function per se, and the platelet phospholipid. So if you look at the top of the slide, so following vessel injury, there will be exposure of collagen from the vascular subendothelium, and I I will be showing you few schemes in my later slides. So upon vessel injury, the collagen will be exposed, and this will induce platelet release reaction. So the platelet release reaction will be responsible for three main things. It will be responsible for release of serotonin from the platelet granules that I discussed before. That will cause vasoconstriction. It will also be responsible for liberating thromboxane A2 as well as ADP that will help in the process of platelet aggregation and ultimately forming the primary hemostatic plug that will result in fusion of platelets together. The third thing that will happen is activation of the platelet phospholipid that will help the blood coagulation cascade, which will be discussed in another presentation by Dr. Aasi, to release thrombin followed by fibrin and ultimately forming the stable hemostatic plug. So again, following vessel injury, there will be automatic vasoconstriction of the blood vessels to reduce blood flow. This vasoconstriction can be helped by serotonin and thromboxane A2 that will be liberated from platelets to aid in the process of vasoconstriction. Vessel injury will result in collagen exposure and ultimately liberating platelet phospholipids and serotonin and causing platelet release reaction with the ultimate liberation of thromboxane A2 and ADP. The third thing that would happen following vessel injury, liberation of tissue factor, activation of the blood coagulation cascade to eventually form fibrin and the stable hemostatic plug. So as you can see from the slide, all processes are interrelated. Now, moving into the specific function of the platelets. So what are the platelet functions, or how do the platelets act in the process of hemostasis? The first thing that will happen is the process of platelet adhesion, followed by platelet activation and secretion, then platelet aggregation, and then platelet procoagulant activity. So these are the steps for platelet activation. So starting by platelet adhesion, as I mentioned before, following vessel injury, there will be exposure of collagen from vascular endothelium, and this collagen will attract platelets that will bind to components of subendothelium via certain receptors, which I will be showing you in my next slide, called glycoprotein 1B19, glycoprotein 1A2A. So the binding of platelets to the subendothelium at the areas of exposed collagen via these receptors, aided by the presence of collagen von Willebrand factor, will be the first step in platelet activation. This is a scheme to clarify how does the platelet activation happens. Again, following vascular injury, there will be exposure of collagen. This collagen will be exposed to areas of subendothelium. It will be exposed. This exposure will attract the platelets that will come and bind to the exposed collagen via certain receptors that I just mentioned, glycoprotein 1B9 and the glycoprotein 1A2A. These two receptors, as you can see here, are responsible for the process of platelet adhesion. So glycoprotein 1B, that facilitates adhesion of platelets to areas of denuded endothelium, and the glycoprotein 1A as well, responsible for the process of adhesion. This process of platelet adhesion is facilitated and occurs only in the presence of von Willebrand factor. So von Willebrand factor is very important for the process of platelet adhesion. In other words, platelet adhesion does not occur via these receptors without the presence of von Willebrand factor. So anytime anytime you are asked about the process of platelet adhesion, it's very important that you know two important things. The process occurs via the glycoprotein 1B19, glycoprotein 1A2A receptor, facilitated by the presence of von Willebrand factor. This is another scheme that can clarify the process of platelet adhesion. So again, if you look here to the areas of denuded endothelium, you can see that the platelet was attracted to this site via glycoprotein 1A2A and glycoprotein 1B19, and this adhesion process occurs only in the presence of von Willebrand factor, as you can see here. So now I think the process of platelet adhesion is very clear after showing you these schemes. Following platelet adhesion, the platelets will become activated. So once the platelets are activated, there will be liberation of their substances from two sources that I showed you in my initial slide. The platelet alpha granules will be liberated, including the von Willebrand factor, platelet factor 4, thrombospondin, fibrinogen, and so on. And the platelet dense granules will also be liberated, including the ADP and serotonin. Okay, so following platelet adhesion, platelet activation occurs whereby the platelets start liberating its granules, whether in the alpha granules or in the dense granules. So again, going back to the scheme that I have just showed you, if you look to the platelet adhesion process that we have just discussed, once platelet adhesion occurs, the platelet granules, the alpha granules, if you look up, and the dense granules will be liberated. So these granules will help in the subsequent process of platelet aggregation. So what does platelet aggregation means? Platelet aggregation means the process by which platelets aggregate together following the process of platelet adhesion. So this is a scheme also showing how two platelets are aggregated together. So this is a platelet and this is another platelet. So the aggregation happens through another receptor called glycoprotein 2B3A. Glycoprotein 2B3A in both platelets will cause platelet aggregation in the presence of fibrinogen that is liberated from the platelet granules. So again, following the process of platelet adhesion, the platelets get activated and their substances get liberated to help in the subsequent process of platelet aggregation. So platelet aggregation, whereby platelets aggregate together, occur via a second receptor called glycoprotein 2B3A, facilitated by the presence of a substance liberated by the granules of platelets called the fibrinogen. So this is the third step in platelet activation. Again, this is just to repeat what I have just mentioned. Now, once platelets aggregate or want to aggregate, actually the fibrinogen binds to the conformationally altered glycoprotein 2B3A receptor on two or more adjacent platelets, resulting in platelet aggregation and accumulation at the site of vascular injury. So other platelet agonists also can contribute to this aggregation phenomenon. However, the most important of which that you should all know is the fibrinogen. So fibrinogen is responsible for the process of platelet aggregation, while von Willebrand factor is responsible for the process of platelet adhesion. Again, this is just to re-stress on the point by which platelets become aggregated together. So glycoprotein 2B3A on both platelets or more platelets, they get bound together via fibrinogen. Now, how does these receptors get activated? These receptors actually get activated by ADP to stimulate the process of platelet aggregation. So once ADP is liberated from the granules of platelets, it results in what we call a conformational change in glycoprotein 2B3A to help the process of aggregation only in the presence of fibrinogen. So basically, ADP is important for the conformational change. However, for the aggregation process, only fibrinogen is important. And this is very important that you know the difference between the two. So ADP is not responsible for platelet aggregation, only fibrinogen. However, ADP will result in a conformational change in the glycoprotein 2B3A receptors so that they can recognize each other and aggregate together in the presence of fibrinogen. So later on, the platelets will interact with other coagulation factors, particularly via the platelet phospholipids that I showed you in my initial slide. So once the platelets get activated, the platelet phospholipid will help the coagulation cascade in order to result in formation of the final platelet plug. Now, this is a question just to refresh our memories. So the normal hemostatic response to vascular damage depends on three major factors. Which one of these is not included in that group? Is it the blood vessel wall? Is it stasis of blood flow? Is it circulating platelets? Is it blood coagulation factors? So if you go back to my initial the initial part of my presentation, we mentioned that following vessel injury, three processes occur. One is vasoconstriction of the blood vessel wall. So the blood vessel wall is important. The other is activation of circulating platelets. So circulating platelets is quite important. The third is activation of the coagulation cascade via liberation of tissue factors. So the blood coagulation factors are very important. So the one that is not included is stasis of the blood flow. So stasis of the blood flow is a wrong answer. Now, what are the causes of platelet disorders? So we have acquired platelet disorders and we have inherited platelet disorders. So acquired platelet disorders, as its name implies, results from certain diseases that can result in a malfunction of the platelets. Okay, so if we are going to talk about platelet disorders, it's very important to know that platelet disorders comprises two important entities. A disorder in platelet number, whereby the platelet number is quite low, a phenomenon called thrombocytopenia, and a disorder in platelet function that could be inherited or acquired. Now, starting by the disorder in platelet function, so the acquired platelet functional disorders could be related to liver disorders or liver diseases, uremia or kidney diseases, dysproteinemia or the presence of abnormal paraproteins in the blood. Other acquired platelet functional disorders could be related also to certain bone marrow disorders like myeloproliferative disorders, which I will not discuss now as you will have a separate presentation on what are myeloproliferative neoplasms, diabetes mellitus that can result also in some sort of platelet dysfunction, and last but not least, the drugs. So we have certain drugs that can affect the platelet function, the most important of which are aspirin, non-steroidal anti-inflammatory drugs, dipyridamole, clopidogrel, and ticlopidine, which are selective ADP antagonists, and glycoprotein 2B3A receptor antagonists. So we have certain drugs acting at different levels of the platelet function activation. For example, we have glycoprotein 2B3A receptor antagonists that antagonize these receptors. We have certain drugs that antagonize ADP. And we mentioned previously that ADP is responsible for creating some sort of a conformational change in the glycoprotein 2B3A receptor to make it able to aggregate to other platelets via fibrinogen. Now, what are the inherited disorders of platelet function? So again, as I mentioned before, disorders of platelets are classified into two major categories. A disorder related to platelet number, whereby the numbers are very low, a condition called thrombocytopenia, and a problem in the platelet function that could be acquired or inherited. So I have just shown you the disorders in platelets related to certain disorders, what we call acquired platelet disorders. And now we will discuss the inherited disorders of platelet function, which are very important for you to know as well. One important disorder is called a giant platelet disorder, what we call Bernard-Soulier. Bernard-Soulier is an autosomal recessive disorder whereby we have circulating giant platelets in the blood, and this disorder is characterized by platelet dysfunction and bleeding. So in Bernard-Soulier, we have a problem in glycoprotein 1B19 that affects the platelet adhesion part. If you recall, we mentioned that glycoprotein 1B19 is responsible for the process of platelet adhesion. In Bernard-Soulier, this receptor is absent, thereby resulting in a platelet dysfunction, particularly at the level of adhesion. Another disorder called Wiskott-Aldrich, which is an X-linked recessive disorder characterized by the presence of immunodeficiency, dysfunctional platelets, as well as thrombocytopenia with microthrombocytes rather than macrothrombocytes. So in Wiskott-Aldrich disorder, we have circulating tiny platelets rather than large platelets, as I mentioned in Bernard-Soulier. So in Bernard-Soulier, we have giant platelets circulating in the blood, while in Wiskott-Aldrich, we have tiny-sized platelets circulating in the blood. We have storage pool disorders like dense granule deficiencies called Shidiak-Higashi syndrome. And another important disorder that you should all be aware of is Glanzmann thrombasthenia. So for your level, the most important inherited platelet function disorders that you should be aware of, and you will be frequently asked in exam questions, is the Bernard-Soulier, the Glanzmann thrombasthenia, and the von Willebrand disease, which I will be discussing in my next slides. So what is Glanzmann's thrombasthenia? So Glanzmann's thrombasthenia is an autosomal recessive bleeding disorder characterized by a defect in glycoprotein 2B3A receptor. And if you go back to my initial slides, you would recognize that this receptor is responsible for the process of platelet aggregation. So in Glanzmann's thrombasthenia, there is a problem in platelet aggregation. There will be mucocutaneous bleeding and no platelet clumping on peripheral smear, which is expected. The platelets will not aggregate together because this receptor is defective. Okay, so again, to refresh your memories, Bernard-Soulier is a disorder of platelet adhesion because the receptor responsible for platelet adhesion, which is the glycoprotein 1B19, is absent. In Glanzmann's thrombasthenia, there is a defect in platelet aggregation because the receptor responsible for platelet aggregation, the glycoprotein 2B3A complex, is absent. We have platelet release disorders, which are really very, very uncommon and not so important for you to know. And sticky platelet syndrome, also another platelet disorder that could cause arterial and venous thromboembolic events. Now, what is von Willebrand disease? Von Willebrand disease is the most common inherited bleeding disorder, and as its name implies, it is due to inherited absence of von Willebrand factor. If you go back again to my initial slides, you would recognize that von Willebrand factor is responsible for the process of platelet adhesion, because platelet adhesion via glycoprotein 1b19 receptor to areas of denuded endothelium does not occur in the absence of von Willebrand factor. So von Willebrand factor is crucial for the process of platelet adhesion. So in its absence, there will be definitely a problem in platelet adhesion. So this disorder is characterized by personal and family history of bleeding episodes, because this disorder is inherited in families. So upon laboratory studies, we usually have normal platelet counts. We have a prolonged bleeding time, because bleeding time is a reflection of the function of platelets. When the platelets are dysfunctional, the bleeding time, which is a test to detect the dysfunction of platelets, becomes prolonged. We have normal PTT and we have prolonged APTT, and we have poor aggregation in response to ristocetin. Now let me explain or discuss why do we have prolonged APTT. Now, von Willebrand factor is carried also by factor 8. So when von Willebrand factor is deficient, factor 8 also becomes deficient. So that's why you would detect prolonged APTT due to concomitant deficiency in factor 8 that is a carrier of von Willebrand factor, or in other words, von Willebrand factor and factor 8 circulate together in the blood, and this will be highlighted more in the other hemostasis lecture that will be given or provided to you by Dr. Hazem Asif. So again, if you are asked about the laboratory findings in a patient with von Willebrand disease, those patients usually have normal platelet count, because the problem is not in the platelet number but rather in the platelet function, which is mainly the process of platelet adhesion. We have a prolonged bleeding time. The bleeding time is a measure of the function of the platelets in peripheral blood. So whenever the bleeding time is prolonged, we can guess that there is a problem in platelet function. We have normal PT, but at the same time we have a prolonged PTT due to the fact that von Willebrand factor and factor 8 are often circulating together in the blood. And von Willebrand factor is a carrier of factor 8 and vice versa. So whenever there is a deficiency in one, there is automatically a deficiency in the other. And this is why we find a prolongation in PTT. There is also poor aggregation to ristocetin. What is poor aggregation to ristocetin, and what is ristocetin? So to start with ristocetin. Ristocetin is an antibiotic previously used to treat staphylococcus infection. It is no longer used clinically because it was found to cause significant thrombocytopenia and platelet agglutination. And now it is used solely to assay those functions of platelets in vitro in the diagnosis of conditions such as von Willebrand disease and Bernard-Soulier. So in general, platelet agglutination caused by ristocetin can occur only in the presence of von Willebrand factor multimers. So if ristocetin is added to blood lacking the von Willebrand factor or its receptor, the platelets will not clump. So this drug was discovered incidentally when it was used previously to treat staphylococcus infection to cause platelet agglutination. And investigators at that time tried to find out the reasons behind platelet agglutination for the patients treated with ristocetin. They eventually discovered that this antibiotic caused agglutination when von Willebrand factor and glycoprotein 1b19 were both present in normal conditions, and this is why this antibiotic was withdrawn from the markets. It is only now used to detect the disorders of platelet function. So, how do we diagnose von Willebrand disease? So when you do the ristocetin test, when you add ristocetin to plasma of a patient that lacks von Willebrand factor, the platelets will not clump, so the platelets will not attach or adhere. There will be poor aggregation to ristocetin, and this is your diagnosis of von Willebrand disease. So if either von Willebrand factor is absent or its receptor, which is glycoprotein 1b19, that occurs in Bernard-Soulier, the platelets will not clump and will not adhere, so eventually there will be poor aggregation or poor response to ristocetin. Now, what are the tests that we generally use to test the number and the function of platelets? We take the blood count that includes the CBC to look at the platelet number. Usually, the normal number of platelets ranges from 150,000 per cubic millimeter to 450,000 per cubic millimeter. And blood film inspection, we look at the blood film to see if we have giant platelets circulating, as I previously mentioned in Bernard-Soulier, or tiny platelets circulating like in Wiskott-Aldrich and so on. We measure the bleeding time, which I have just discussed. The bleeding time will be prolonged whenever there is a dysfunction in the platelet, whether adhesion or aggregation. We measure the platelet aggregation phenomena using ristocetin and other platelet agonists. We use, as I mentioned, ristocetin, and we measure their ability to release. For your level, the most important tests that you should be aware of is the ristocetin, which is important to diagnose von Willebrand disease and Bernard-Soulier, and the platelet aggregation tests, which is responsible to diagnose platelet aggregation problems like in Glanzmann's thrombasthenia. So, going back to a blood film or peripheral smear examination, macro thrombocytopenia can be seen in patients with Bernard-Soulier or Alport syndrome. Small platelets are characteristic of Wiskott-Aldrich, which I have just discussed. Bleeding time, again, measures the function of the platelets. However, it is not highly sensitive and specific because we have other advanced tests that are now used in our labs to detect more precisely the problem in the platelet function. So basically, it is definitely used, but it does not have high sensitivity and specificity because bleeding time can be prolonged in the presence of low platelet count. So this tells you that the test is not highly specific for detecting only a platelet function problem. What about platelet aggregation assays? The most important agonists that we use in these assays to measure the aggregation part is the ADP, collagen, arachidonic acid, epinephrine, thrombin, and ristocetin. This is probably the most important slide of the presentation that you should know and recognize very well. So, and this is a summary of the disorders of platelet function that I have just discussed in details. This is to summarize and to refresh your memories. So if you look at von Willebrand disease, the problem is deficiency in von Willebrand factor that affects the process of platelet adhesion. Okay. And to diagnose von Willebrand disease, there is poor aggregation in response to ristocetin because of the lack of von Willebrand factor. Ristocetin will not be able to cause any aggregation and adhesion without the presence of von Willebrand factor. In Bernard-Soulier, again, there is a deficiency in glycoprotein 1b receptor, again, that affects the process of platelet adhesion. There is poor aggregation in response to ristocetin as well because the glycoprotein 1b is deficient. Hence, ristocetin will not cause aggregation. The last disorder is Glanzmann's thrombasthenia. The problem is not in adhesion but rather in aggregation. due to deficiency in glycoprotein 2b3a receptor. And in this disorder, there is good aggregation to ristocetin because the problem is not in von Willebrand factor or its receptor. So ristocetin test is normal in Glanzmann's thrombasthenia. However, there is poor response to other agonists, ADP, epinephrine, collagen, that will affect the process of platelet aggregation, except ristocetin, which will be normal. So you can differentiate between these three tests via ristocetin and other agonists. Now, how to assess platelet function? Besides doing bleeding time, doing aggregation tests, doing ristocetin, we have a new test called the Platelet Function Analyzer, or PFA 100, that has higher sensitivity compared to bleeding time in screening for platelet functional problems, specifically for von Willebrand disease. And this is now mainly used to detect platelet functional disorders rather than the bleeding time on its own. Now, what are the clinical manifestations that differentiate between different types of bleeding disorders, whether related to qualitative or quantitative platelet problems or inherited factor deficiencies, which is the other part of the presentation regarding hemostasis to be given by Dr. Aasi again. So basically, if we want to clinically differentiate between a bleeding disorder related to a problem in platelets or bleeding disorder related to clotting factor deficiency, we can look at the different clinical manifestations that each of these phenomena will cause. So whenever you have a platelet problem, we usually get bleeding after minor cuts. However, with clotting factor deficiencies, bleeding after minor cuts is not common. In platelet problems, we get petechiae, and this is not commonly seen with inherited factor deficiencies. With platelet problems, we see generally superficial ecchymosis. However, we see deep, large hematomas with clotting factor deficiencies. Regarding hemarthrosis or muscle hematomas, so hemarthrosis are muscle hematomas. Muscle hematomas are purely seen in clotting factor deficiencies and are not seen in platelet problems. And bleeding following invasive procedures, including surgery, usually occurs early with surgery or post-procedural. However, it can be delayed with clotting factor deficiencies. In this slide, the most important manifestation that you should be aware of is the presence of muscle hematomas or hemarthrosis, which are very specific to clotting factor deficiencies, and petechiae and superficial ecchymosis, which are very specific to platelet problems. However, deep ecchymotic patches and hematomas, soft tissue hematomas, are more commonly seen with clotting factor deficiencies. This is a slide to differentiate between the two bleeding disorders. This is definitely what we see in platelet dysfunction or in platelet problems, and this is what we see in clotting factor problems, deep, big hematomas. These are superficial petechiae. Now, just to refresh your knowledge about what we have just discussed, which of the following statements is true about von Willebrand's disease? It predominantly causes deep muscle and joint hemorrhage. It is usually associated with low plasma factor VIII level. It occurs mainly in males. It may cause a prolonged PT. So again, if we are going to discuss in more details what do we see often in von Willebrand disease. So to refresh your memories, von Willebrand disease is caused by a problem in von Willebrand factor. And von Willebrand factor can result in platelet problem. And because von Willebrand factor is a carrier of factor VIII. Any deficiency in von Willebrand factor can be accompanied by a deficiency in factor VIII. Accordingly, this question is a bit of a trick just to refresh your memories regarding von Willebrand factor and its importance. So there are two answers that are correct. Only one is highlighted. However, two answers are correct in this question. So, von Willebrand disease is usually associated with low factor VIII level because of the deficiency of von Willebrand factor, which is associated with a deficiency in factor VIII level. And it predominantly causes deep muscle and joint hemorrhage. Why? Besides the fact that it has a platelet problem, it also has a clotting factor problem because it is a carrier of factor VIII. Accordingly, with deficiency in von Willebrand factor and subsequently factor VIII, we can get deep muscle and joint hemorrhage. So in this question, two answers are correct. These questions definitely will not be given to you in your final exams. This is just a trick to refresh more and more your memory, just to be aware of the importance of the von Willebrand factor and its function. Now moving on to abnormalities in platelet number. So as I just mentioned, low platelets are often referred to as thrombocytopenia, which means that the platelet count is below 150,000 per cubic millimeters. These are the causes of thrombocytopenia or low platelet count. So we have failure of platelet production due to megakaryocyte depression, due to certain congenital defects, certain drugs, chemicals, viral infections can cause this megakaryocyte depression. We have a problem in the bone marrow, what we call bone marrow failure syndromes, which you will be taking in separate presentations. So bone marrow failure can be caused by multiple phenomena like cancers, leukemias, phenomena called aplastic anemia, myelodysplastic syndromes, myelofibrosis, which you will be taking later on in other presentations. Other problems that can affect the bone marrow include administration of certain cytotoxic drugs like the chemotherapeutic agents that we give to our cancer patients. Giving radiotherapy also can result in bone marrow failure, and certain viruses can also suppress the bone marrow like HIV infection that can result in a bone marrow failure. Now, so this is what we refer to as failure of platelet production. So there is a problem in producing the platelets in the bone marrow, either by suppressing the megakaryocytes or because we have some sort of bone marrow failure phenomena. Now, the other problem in low platelet counts could be related to increased consumption of platelets. So in this category, we have normal platelets produced by the bone marrow. However, these platelets are being destroyed in the peripheral blood by certain antibodies or in the spleen by certain autoimmune process. So the most important of which is called idiopathic autoimmune thrombocytopenia, what we call ITP, whereby we do not have a clear process of the low platelet count. So there might be probably antibodies in this ITP disorder causing destruction of the platelets in the peripheral blood. That could also be related to certain autoimmune disorders like systemic lupus erythematosus, certain disorders like chronic lymphocytic leukemias, lymphomas. Infections also can result in an immune-related phenomena that can affect and result ultimately in low platelets, drug-induced heparin, DIC, disseminated intravascular coagulation, and a phenomena called thrombotic thrombocytopenic purpura, which I will be discussing shortly. We have abnormal distribution of platelets, like in disorders that result in splenomegaly, which I discussed in my earlier slides. We have dilutional loss due to massive transfusion. So following any motor vehicle accident, we sometimes initiate massive transfusion protocols, and this can result in what we call dilutional thrombocytopenia due to massive blood transfusion. So eventually when you transfuse around 10 to 12 units of packed red blood cells to an injured patient, you eventually need to transfuse platelets to avoid this dilutional loss of platelets. And again, bone marrow suppression that could be related to certain radiation, drugs which I discussed before. Again, immune mechanisms affecting the bone marrow, certain analgesics, anti-inflammatory drugs, antibiotics, certain sedatives, anticonvulsants, like the ones that we use to treat epilepsy can result also in thrombocytopenia. Heparin can result in what we call heparin-induced thrombocytopenia and other medications as mentioned in the slide. What are other causes of low platelets or thrombocytopenia? An important phenomena called gestational thrombocytopenia, which is something that occurs normally during pregnancy. So during pregnancy, many of the pregnant females can develop this gestational thrombocytopenia that returns to normal following delivery. We have a phenomenon called pseudothrombocytopenia or spurious thrombocytopenia or false thrombocytopenia. This is an in vitro sampling problem which may mislead the diagnosis towards thrombocytopenia. It occurs actually due to the presence of an anticoagulant called EDTA, which is present in the CBC tube. And this EDTA can result sometimes in clumping of platelets, which can mimic a low platelet count. To overcome this spurious thrombocytopenia or pseudothrombocytopenia, we often ask our patients to repeat the CBC in what we call a citrated tube to overcome the phenomena of clumping of platelets using the EDTA tube. To refresh your memories again, which of the following causes thrombocytopenia? Essential thrombocytosis, aspirin, infectious mononucleosis, or iron tablets? Now, what is the correct answer here? Going to essential thrombocytosis, this is a phenomena characterized by high platelets rather than low platelets. So definitely this is not the correct answer. Moving on to aspirin, as I mentioned earlier in my slides, aspirin can result in a dysfunction in platelet function actually, and not in platelet number. So aspirin does not cause thrombocytopenia. Infectious mononucleosis is an infection caused by virus called EBV, Epstein-Barr virus, and this virus definitely can result in low platelets, as I mentioned in my slides. So infectious mononucleosis is the correct answer. Iron tablets is not true because iron does not cause thrombocytopenia. Now, what is the pathogenesis behind autoimmune thrombocytopenic purpura, what we call ITP, which is one of the most common causes actually of autoimmune thrombocytopenia? Well, in ITP, we do not have a clear reason for thrombocytopenia. However, there is this phenomenon of the presence of antiplatelet autoantibodies that can bind to the sensitized platelets, and these sensitized platelets will eventually get engulfed by the macrophages through the Fc portion of the antibody. So we have antibodies for whatever reason circulating in our blood that can attach to the platelets. The platelet will get sensitized and engulfed by the macrophages that will eventually be destroyed in the spleen. So this is a proposed mechanism for ITP or immune thrombocytopenic purpura. So in ITP, isolated thrombocytopenia is present. In the majority of cases, it is acute. in 85%, or it could be chronic in minority of cases, around 15%. In children, it is mostly acute. However, it's very important that we exclude secondary causes. The first line of treatment is steroids. When you give corticosteroids, usually the platelets improve within 5 to 7 days. Gamma globulin or IVIG can cause temporary improvement in platelet count, and we usually resort to gamma globulins whenever we have a life-threatening bleeding. So we start by IVIG because it acts quickly to increase the platelet count immediately. Splenectomy, it's often considered for long-term improvement in patients who recur despite steroids and IVIG. And splenectomy can often result in cure from this phenomena in around 60% of patients. We can also use rituximab, and we can also use other thrombopoietin agonists that act to help the bone marrow produce more and more platelets. However, this is beyond our discussion now. What about TTP? TTP could be familial or acquired. TTP means thrombotic thrombocytopenic purpura. There is a deficiency of metalloprotease or caspase enzyme, which is responsible for breaking down the high molecular weight multimers of von Willebrand factor. TTP is characterized by fever, severe thrombocytopenia, microangiopathic hemolytic anemia, and neurological symptoms. The characteristic laboratory findings in TTP include the presence of schistocytes on peripheral blood. This is the most important pathognomonic finding. Elevated retic count, LDH, low haptoglobin, and low platelets. The first and most important and urgent treatment is plasmapheresis or plasma exchange. So how does TTP occur, or why does TTP occur? Under normal conditions, we have this protease that is responsible for cleaving the von Willebrand factor, the ultra-large von Willebrand factor multimers, into smaller ones. And these smaller ones will be used for the process of platelet adhesion, if you recall the initial presentation. Okay, so we have ultra-large von Willebrand factor multimers, which will be cleaved by this protease enzyme to the regular von Willebrand factor multimers that will be used to facilitate the process of platelet adhesion. In cases of TTP, in acquired TTP specifically, we have an antibody targeting the protease enzyme. So the protease enzyme will not be able to cleave the ultra-large von Willebrand factor multimers into the regular small von Willebrand factor that is responsible for the process of platelet adhesion whenever vessel injury occurs. On the contrary, these ultra-large von Willebrand factor multimers will attract the platelets because they are thrombogenic. So they attract the platelets, and the platelets will adhere and aggregate, resulting in what we call TTP. In familial TTP, there is inherited deficiency of this protease that is responsible to cleave down the ultra-large von Willebrand factor multimers into the regular von Willebrand factors. And this again will lead to accumulation, aggregation of platelets, because these are the ultra-large von Willebrand factor multimers have a very strong aggregation potential, and they will ultimately attract all the platelets to aggregate and adhere, even in the absence of any vessel injury, which is definitely a pathological event. These are the schistocytes that we often see in TTP. This is a schistocyte, this is a schistocyte, this is a schistocyte, this is a schistocyte, what we call fragmented red blood cells. And this is a schistocyte, these are pathognomonic findings in TTP. So to diagnose TTP, we need to have schistocytes in peripheral blood. We also need to have low platelets, sometimes hemolytic anemia, elevated retic count, and elevated LDH. Now, which of the following statements is true about ITP? It is usually chronic in children. It may be treated by gamma globulin infusions. Steroids are contraindicated. Peripheral smear shows fragmented red blood cells. Again, to refresh our memories, ITP is usually acute in children. It is not chronic. It might be chronic in adults. It is usually acute in children. It may be treated by gamma globulin infusion. Yes, this is correct. Gamma globulin infusion is often administered whenever there is life-threatening bleeding because it immediately increases the platelet count within 24 hours, while steroids might need around 5 to 7 days. Steroids are contraindicated. This is false because steroids are the first line of treatment of ITP. Peripheral smear shows fragmented red blood cells. This is false, definitely. This is wrong because this is only seen in TTP, not ITP, fragmented red blood cells or schistocytes. This is the correct answer. Now, this is a syndrome called HELP syndrome. HELP syndrome is a life-threatening obstetric complication usually considered to be a variant of preeclampsia. It usually begins during the 3rd trimester of pregnancy, and it is characterized by hemolysis on peripheral blood smear with elevated serum LDH, elevated liver enzymes, aspartate aminotransferase, and low platelet count. So in this setting, if you see a pregnant patient in the 3rd trimester with thrombocytopenia, you should always exclude HELP syndrome. Okay? We have, again, just to refresh your memories, in pregnant ladies, we often see what we call gestational thrombocytopenia. Gestational thrombocytopenia is a normal phenomenon. However, the difference between gestational thrombocytopenia and HELP syndrome is that in gestational thrombocytopenia, we have isolated low platelet count, isolated thrombocytopenia. In HELP syndrome, we have elevated LDH, we have hemolysis, we have elevated liver enzymes, SGOT, SGPT, and this is a life-threatening complication that prompts immediate delivery of the baby to save the life of the pregnant lady and her child. So in general, what are the treatments that we use to treat platelet disorders? So we have desmopressin or DDAVP. So desmopressin can be used to correct the hemostatic defect in von Willebrand disease. Why? Because DDAVP helps liberation of endogenous von Willebrand factor from the endothelium. Again, to refresh your memories, von Willebrand factor is present in the subendothelium and it is present within the platelets. So, and it is also circulating in the blood bound to factor 8. So we have several sites for the von Willebrand factor. So in setting of von Willebrand disease that is characterized by deficiency of von Willebrand factor, the use of DDAVP helps liberation of endogenous von Willebrand factor from the endothelium. It can prevent bleeding after dental extraction in patients with mild platelet defects. Previously, estrogens were used for uremic bleeding, but this is really not used anymore. Platelet transfusion, definitely for severe uncontrolled bleeding. We can transfuse platelets whenever there is severe uncontrolled bleeding. And for antifibrinolytic agents also can be used following dental extraction. For the condition that I previously mentioned called thrombotic thrombocytopenic purpura or TTP, the only treatment for this condition is plasma exchange or plasmapheresis and not platelet transfusion. Recombinant factor 7. So recombinant factor 7 is often used for those with refractory bleeding, those patients who cannot receive platelets because of alloimmunization or antibody formation to platelets. We can use recombinant factor 7 because it can bypass all the coagulation cascade. So recombinant factor 7 is often used in severe life-threatening platelet function disorders to help control the bleed. It is definitely not used for minor bleeding events. Sometimes, again, as I mentioned earlier, we can use platelet transfusion for those patients who have low platelet count or a problem in platelet function, if they are bleeding or if they have a planned surgical intervention. And recombinant factor 7 is approved in Europe for use in patients with Glanzmann's thrombasthenia and Bernard-Soulier who are refractory to platelet transfusions and who are bleeding actually. So as a final reminder, how to assess for platelet problems or platelet disorders. If we have low platelet count, it is important to consider screening tests for DIC or TTP. Look for certain antibodies, consider the diagnosis of ITP, and if our diagnosis is not met, we can consider bone marrow examination to assess whether there is a problem in reproduction, in the production of platelets in the bone marrow. Regarding normal platelet count, so if we have a normal platelet count, we need to assess the function of these platelets. So we measure the bleeding time. We can do platelet aggregation studies like ADP, collagen, ristocetin, other platelet special tests, adhesion studies, nucleotide, pool measurement, and so on, and then von Willebrand factor assay, PFA 100 that I previously mentioned, and so on, to be able to reach our final diagnosis whenever a bleeding diathesis is diagnosed in a certain patient.